Now I'd like to invite our panel titled Addressing Trauma Through Holistic Support to the main stage. We're kicking off our day with this important panel, and it's being moderated by a journalist, Anna Muto, who some of you may know her work. She wrote the article Addressing Maternal Mental Health that published last year, titled The Tragedy of Being a New Mom in America. I have goosebumps again. The headline says it all, and it caught the attention of millions of readers across America. She now works as a reporting fellow at the Financial Times, covering healthcare and more. And before becoming a freelance journalist, she spent 20 years as an investment banker, including serving as a senior vice president at Goldman Sachs. Anna is passionate about following the money. I love it. Women's rights and equality. Amen to that, Anna, and welcome to the main stage, the full panel. Anna, it's my deep pleasure to turn it over to you.
Thank you so much, Joy, for your introduction. And also thank you to Shanita for sharing your meaningful and inspiring story. Thank you, everybody, for joining our session over the next 45 minutes today, addressing trauma through holistic support. I'm super excited because with us, we have an incredibly robust and well-rounded panel to talk about some of the challenges of being a new mother in America, but most importantly, how we can provide holistic solutions. So I'd like to ask for each of our panelists to share your name, organization, title, and a quick statement about your work, please. Maybe we can start with Dr. Sarah Johnson.
Good morning, everyone, and thank you, Anna, and thank you, Joy, and to everyone in attendance. It's wonderful to be here. My name is Sarah Johnson. I'm an obstetrician gynecologist. I work with the ACEs Aware initiative in California to advance trauma-informed care in reproductive health, including screening for adverse childhood experiences in prenatal care. And I'm a clinician at La Clínica de la Raza, which is an FQHC in the San Francisco Bay Area.
Thank you, Dr. Johnson. Let's move on to Dr. Sharon Deckel.
Thank you, Anna, and thank you, everybody, for coming and attending our panel today. It's such a delight experience to be part of this important event. My name is Dr. Sharon Deckel. I'm assistant professor of Harvard Medical School, and I'm the founding director of the Postpartum Traumatic Stress Disorder Research Program at Massachusetts General Hospital Department of Psychiatry. My scientific work is focused on the study of PTSD stemming from a traumatic childbirth experience and comorbid conditions. I also treat in prior practice individuals who are in the peripartum period.
Thank you. Tanisha Gaines, go ahead, please.
Hi, everyone. Thank you for joining us here today. My name is Tanisha Gaines. I am Director of Operations and co-founder of the Village of Healing. And we are a healthcare clinic, Black-led ran clinic, who we offer culturally sensitive, and we use a holistic approach to care to produce better overall health outcomes for our Black families. And I'm happy to be here today.
Great, thank you. And last but not least, Dr. Elizabeth Familia.
Thanks so much, Anna. It's great to be with everyone. Truly an honor to be here. I'm Elizabeth Familia, Deputy Director at the Child Parent Institute in Santa Rosa, California. We serve all of Sonoma County as a family resource agency. Our mission is to end child abuse by strengthening the health of children, parents, and families. And we do have a continuum of care that includes child and family therapy, parent education. We have a non-public school, and we also have a strong perinatal mood program for new moms. Thank you.
Thank you. So since everybody gave more of an overview of the community you serve and what the program provides, maybe you can tie in more as you answer some of these questions. So I'm going to jump to the first question with Dr. Johnson. First, my goal is to lay out the land of holistic support and first understand the current challenges that some of these new mothers face. So Dr. Johnson, let me start with you. As an OBGYN, what did you see as the biggest hurdle in caring for new mothers that you wanted to improve upon? If you can perhaps share with us a pivotal moment or experience that ultimately led you to carrying out a quality improvement study.
Sure. Yeah, I think, there are so many, but I think a big hurdle that we're all dealing with here is that our paradigm and our systems separate the mental and the physical. And that's not an accurate paradigm, and it really hobbles our efforts to do the work that we're all trying to do of really taking care of our patients. And I'm grateful to have this topic be holistic care and for all the work that everyone's doing, because really I think what we're doing is healing that fundamental separation. The science of adverse childhood experiences and of trauma and of resilience also really are advanced in bringing together the mind and the body, and I think show us important ways forward in addressing all of these challenges. They really are so resonant with what the speaker was talking about this morning. And yet, how to understand the impact of trauma on people's lives, not just in mental health conditions, but in their whole experience, how that shows up in reproductive health care, in the conditions and experience. That was not part of my residency training as an OBGYN. And that's something that's absent from most people's training today. And yet it's a really big deal. I'm sure many listeners are familiar, but just a little overview of ACEs, or adverse childhood experiences. These are potentially traumatic events that occur during childhood that can affect health throughout life and into adulthood. And often when we think about ACEs, we think about the 10 categories that were in the original Kaiser Permanente ACE study that really opened the eyes of the medical field to the interconnection between adversity and trauma and health. And these include abuse, neglect, and household challenges, things like having a mother with a mental health condition in the peripartum period. These things are common, and they impact people throughout the life course. We really understand now that so much of health and of disease is driven by a balance between early experiences of adversity and also early experiences of support and positivity. So we see, for example, that these are highly salient during the perinatal period. This is something that people are carrying with them when they're pregnant, often silently, without support, and accompanied by shame and stigma that goes along with associated health conditions. These are ghosts that are following people through their pregnancy that they aren't able to talk about or share. And from a medical perspective, these are associated in a really significant way with conditions that we're trying to treat. High ACEs confers a 6-fold risk of substance use disorder during pregnancy, a 5-fold risk of experiencing postpartum depression, a 37-fold risk of committing suicide. So these are really significant things that are impacting our patients that we're not addressing. And there's an intergenerational cycle here and an intergenerational opportunity, right? Because a mom's mental health conditions or health conditions that stem from ACEs can then become the ACEs of a child. And we're really just sitting in the midst of this propagation of an intergenerational cycle. But by treating those conditions, by carrying this with a mom, and by increasing positive experiences and supportive experiences for the family and the baby, we can interrupt that. And as a clinician, when I started integrating this understanding into my practice, I really started to see how powerful it was. That, I'm not a therapist, but just listening and supporting is a therapeutic intervention. And that when I was able to hold that with my patients and understand that for many of them, this intergenerational transfer, passing this on to their baby is, for some people, the thing they're most concerned about in their pregnancy. So being able to walk with them in that. And then understanding that holistic support makes a difference, even if someone doesn't have a diagnosed mental health condition, that we can work just with me on nourishment and sleep, and with my clinical team on expanding support and bridging that out into community supports and public health and mental health where it's needed. So that's why it's wonderful that you guys have this panel really shows kind of all the ways this shows up.
Great. Thank you, Dr. Johnson. So in terms of practicality, because an OB has their lane and other caretakers have their lane, what would be a first step that you recommend other caretakers to take in order to learn more about the ACEs screening or timing to implement?
Yeah, I did a project with the California Maternal Quality Care Collaborative, looking at stakeholder input and expert advice and available research that really kind of lays out steps that we can take. And that's in a paper that I made available with the resources here. But it's starting to absorb that sensitivity to trauma, that trauma-informed approach, things like choice and voice when we're touching people, collaborative care, culturally responsive care. And then I do think that starting to directly offer an opportunity to address and discuss this with patients is meaningful. We're not trying to pressure people to tell us their stories, but we want to give them an opportunity to disclose. ACE screening is one way to do that, so that we can offer support and collaborate on more holistic plans. And I am really eager to connect. This is early. We're early in addressing trauma compared to where we are in some of the other conditions, but I think we have to bring this in as we stand up more holistic systems, right? It's not just multi-dimensions, it's 4 dimensions. It's early, later, next generation. So I'm really eager to connect with anyone that's interested in championing this and would love to support.
Great. Thank you so much, Dr. Johnson. I'll turn it over to Dr. Deckel. Your earlier training has been in PTSD treatment for veterans, and maybe you can expand a little bit on that as well. And now you focus on new mothers with birth trauma. Could you please share with us what is the most common feeling among mothers who experience birth trauma? Maybe we can start with there, and then I'll ask more questions.
Sure, that's such an important question. I think it's important to think about these psychological responses of women who experience birth trauma in a larger context, and that would be the context of the norms and the expectations of society of delivering moms. So when we think about going to war, everybody would agree this is a horrific, dangerous, traumatic experience. When we think about childbirth, the uniform notion is that childbirth is a happy event, especially if the mother is physically well and the baby is healthy. And I think psychologically, there's some kind of distance from being able to really acknowledge that birth could actually be a highly stressful and even traumatic experience for significant women. And in this context, I think kind of echoing what Dr. Johnson was saying, we see that people who experience PTSD of childbirth, their, I would say, wounds and their injuries become invisible. And this really reminds me what we know from the 1970s when we had veterans, Vietnam veterans, and there was very limited acknowledgement to the fact that these people are really having psychological distress to the level of mental illness. And I think back then, and this might be relevant for postpartum women who endorse PTSD these days, to some extent, there is I believe, notion that their symptoms are possibly like we talk about the hysterical woman or the hysterical mother, versus childbirth could actually be an event of such an extreme magnitude psychologically that without giving birth, you would not have PTSD. And of course, there are risk factors, and some people are more likely to have PTSD of childbirth versus other. This is what we call like the premorbid factors. But as I tell students in my lab, without giving birth, you could not have childbirth PTSD. So this is like one of the unique, I would say, characteristics of PTSD, that the disorder is defined by exposure to a causal external event. Without this exposure, you would not have the disorder. So going back to your question, in this context of, I would say, taboo on the one hand, and the societal expectations on the other hand, in the course of interviewing hundreds of women in our lab, Massachusetts General Hospital, and some of them were even a decade since the time they gave birth, people talked about the fact that they never shared their birth experience and knew often that something is going wrong with them, but they didn't really have a label for the disorder. And it was very difficult to actually make sense. And then women would talk about feeling shamed. So this is, I think, definitely ties into this very high expectations of delivering mothers, and which I think in part these days are fueled via social media. So people would talk about feeling shame, that I did not have the perfect birth experience as my girlfriends, and I feel shamed. I feel that people feel very uncomfortable listening to my story because people want to hear positive events, not traumatic childbirth experiences. And women often talk about feeling guilty. So they would say, I didn't have a vaginal delivery, therefore I failed my baby. And in a way that I would say to a level, this is what PTSD is all about, that the guilt is in a level of the distortion that even if you explain to the person, this is actually maybe the best option was at the time point to have a cesarean, for example, still the fixation would be on feeling very guilty. And I think the guilt and shame are definitely largely triggered or maintained because of our society, including, I think, the medical system. And then many people never talk about their symptoms, never receive treatment. And what I think makes this reality even more unfortunate is that there are people who speak up, and there are, based on our studies, women, patients who know that something is really wrong. And often they would discuss their condition, their mental health burden with their providers. Often this would be the obstetricians. And a common response would be either, maybe this is postpartum blues, so this will kind of go away and just kind of normal coping, or maybe you actually are experiencing postpartum depression. So, when I hear how we are thinking about postpartum depression and PTSD as possibly the same conditions, it's like somebody would say, well, you had stroke and then you have a heart attack, and that's kind of the same condition. These are different conditions that require different type of treatment. So I believe in today's reality, and women in America often do not receive the treatment that could potentially prevent PTSD or from PTSD becoming an enduring condition. And the cycle is very vicious because women often would avoid giving birth. They would avoid becoming pregnant again, which is, avoidance is a core feature of PTSD. And often women would nevertheless somehow force themselves to be pregnant and give birth again. And they are giving birth under conditions of often of unresolved PTSD. So we are talking about a very vicious cycle because we know that unresolved PTSD, like other unresolved mental illnesses, could lead to adverse birth outcomes. And women who have unresolved PTSD often have very difficult time taking care of their child that relates to their first pregnancy and also to the second pregnancy. So kind of echoing what Dr. Jensen said, we are talking about PTSD of childbirth possibly having intergenerational effects. And how can we as a society come up with a better plan to make sure that we are not like stuck in the 1970s and treating postpartum women as if they are Vietnam veterans? Because for Vietnam veterans, and to my knowledge from doing research on veterans and soldiers, there are in place a lot of programs that would promote resilience, a lot of programs that we focus on early screening, early treatment. But when it comes to the childbirth PTSD, it's somehow not really existing, or at least not in a routine way, like I would like to see it.
Thank you. Thank you for walking us through that. I think when you said the most common feeling is shame, that really resonates, because in my reporting, when I wrote the story, that was something that really came through strongly, as opposed to some of the other more structural healthcare related hurdles that many new mothers face. Could you talk a little bit about, so we've established that childbirth PTSD is separate from mental health. Sometimes it's interrelated. Sometimes it could happen at different moments. But could you talk a little bit about how prevalent is childbirth PTSD and how would we screen for it? Who should we screen?
The field of childbirth PTSD in terms, I would say the scientific investigation is really something that is emerging. Definitely over the past 5 years, we see a lot of work coming from the US and also from Europe. And I believe we don't have good enough estimations. From what we do know, I would say that on average, 6% of American women are likely to experience childbirth PTSD, which would be 6% of women and potentially risks transmitted to their infants. Nevertheless, I think it's important to focus on high-risk groups. So for example, women who have medically complicated deliveries, based on our lab's work and other teams, we know that, for example, women who go under unplanned cesareans or emergency cesareans, or even more severe, what we call severe maternal morbidity, then the rates of PTSD range between 20 to 44%. So 1 out of 5% women who have complicated delivery developing PTSD, it's comparable to rates of physical violence, that people have physical violence and also develop PTSD. And it's important to also emphasize that when we talk about childbirth PTSD or birth trauma, we see that there are very critical disparities in responses to birth trauma. And as we're talking about, into your question about the prevalence of maternal PTSD or CPTSD, childbirth-related PTSD, based on our research, we find that 1 out of 3 Black and Latina women are likely to endorse an acute stress response to childbirth and therefore have a risk of PTSD versus white women that is 3 times higher. In our research, this finding was observed when we accounted for OB complications. So it's not stemming because possibly underrepresented minorities are experiencing more physical morbidity, but as you know, it's difficult to consider, but it might be that to some extent we are talking about structural racism. And again, you know, as we are thinking about how can we improve our health system and make sure that people feel safe when they're giving birth and they feel they can trust the medical system, definitely a lot of attention needs to focus on this idea of equity and that all women in the US would feel safe when they're giving birth. In terms of the best way to screen for PTSD of childbirth, then the most common way to screen for PTSD in general is using the CAPS. The CAPS is clinician structured interview. It would take between 45 to 60 minutes to administer. And this is really a clinician who's trained would, through this course of an interview, would review all the DSM-5 PTSD symptoms of the patient. This possibly might not be the best solution for postpartum mothers, given the magnitude of childbirth PTSD, which is, as I stated, is clearly not a rare condition, and potentially an alternative way to screen for childbirth PTSD, at least at the level of a provisional clinical diagnosis, would be with the use of a questionnaire. And in our recent work, we have shown that the PTSD checklist for DSM-5, which is the PCL-5, which is a #1 questionnaire to self-report questionnaire to assess for PTSD recommended by the VA. We showed that in the sample of women who had CPTSD, we compared this PCL against the CAPS, and we see that the PCL is able to offer really high level of accuracy in detecting CPTSD in women who had complicated deliveries. An important component to emphasize when we talk about CPTSD is that, unlike other conditions, there is a very clear onset of when the symptoms develop. So this would be childbirth or once the person is exposed to a traumatic event. So usually within days, we would see symptoms of CPTSD. So there is a clear opportunity for early detection before people would even have what we call the full-blown disorder, that by the DSM, a person can have PTSD only a month. The earliest would be a month following exposure. So as we often talk in our lab, we know when the symptoms are developing, that would be really in the immediate postpartum. In the immediate postpartum, women are actually at the hospital for the majority if they give birth in the hospital setting. Because PTSD is highly likely to occur among women who have complicated delivery. Usually people have complicated delivery, at least based on but data that I know at my hospital at MGH, they stay actually in the hospital for several days. So there is a lot of opportunities for early screening and ideally also providing preventive intervention to possibly buffer any kind of chronic manifestation of PTSD and its implication on the developing child. What we have begun doing is we have begun examining the utility of birth narrative. So we ask in our studies, we ask participants to provide a childbirth narrative, which would be of 30 words and not more. And we are employing in AI and machine learning models. And we see that possibly by asking people to briefly share with us their story, these narratives could possibly be a way to early on detect PTSD. And this is like a work still in the making. But again, there's just, I think it's, we know that early intervention can prevent mental health disorders. And we also know that the first step of preventing something is actually accurate screening. How can we identify people who are the highest risk for having maternal PTSD? And I think that collaborating between the Department of Psychiatry and the Department of OB in a very kind of serious and concrete way in which we would be able to use information coming from medical records or information from providers to identify people who have complicated deliveries, this could eventually help us administer the PCL to people who are the highest risk. So we have kind of very efficient and possibly selective screening. And based on the results of the screening, we could direct individuals to receive the treatment that they would ideally benefit from and prevent those symptoms and make them feel empowered to then consider giving birth again. Because to me, the idea that you are afraid of giving birth because of an unresolved mental illness as a woman and as a mother, I find it very, very upsetting.
Yeah, thank you so much for explaining all of that. It's hopeful to hear that AI is also being used in a positive way to resolve this. So now I'd like to shift our focus from studies and screening to more on-the-ground practice when it comes to new mothers and their families. Tanisha, you've worked in big hospital settings in Ohio and also for maternity care, but also you set out to found a clinic focused on Black mothers and families. I actually had the pleasure of visiting your clinic, which was absolutely phenomenal. Can you talk about some of the challenges specific to Black mothers where the stats are really bad when it comes to childbirth and many other health issues as well? And if there are any aspects that are commonly misunderstood at big hospital settings?
Thanks, Anna. I think when we talk about that, working for that large hospital institution here for over 20 years and understanding that what Dr. Deckles talked about, that systemic racism, right? So these institutions were built on that. And so for us walking into those institutions is that lack of trust. It's that not being heard, not listened to, and not seeing people that look like us. And we know that with the studies that have came out recently, that if you have a provider that looks like you and that takes care of you and listens to you, your health disparities are decreased. For us, creating that our space and our clinic focus on Black families and moms, we wanted to make sure that we have that culturally sensitive care and that space you can walk in where you feel safe, where you feel like you're at home. Because we know and that we have people that look like you, and that we know that those providers are there. They're from your community. They shop at the same grocery stores you shop at. They go to the same, in the same neighborhood you are in. So they understand what you're going through, because we know that only about 20% of what affects your life happens in that healthcare setting. That other 80% is what happens outside of that healthcare. So for us, we want to make sure that we are addressing that 20%, but also that 80%, and offering that community programming within our center, and having our moms and their families come in for that care that they deserve with providers that look like them, who has been through what they've been through, who are care providers, who have been in these systems as not only employees, but as patients as well, and have went through the things that they went through. And understanding also that when we talk about health disparities, infant mortality, maternal mortality, that when we change the narrative that this is not a poor Black woman problem. We hear a lot about infant and maternal mortality. You hear about the Medicaid population, and you hear about poor Black women. But what people don't understand is that it doesn't matter your socioeconomic status. All Black moms are affected by infant and maternal mortality and health disparities. Myself, having a baby at 39 years old, I'm 30 and over with a graduate degree, I'm 6 to 7 times more likely to die from childbirth complications than a white woman without a high school diploma. So I'm not a poor Black woman, but we have higher rates of these health disparities. So we have to understand what that looks like, being a Black woman in leadership, walking into these institutions, dealing with microaggressions daily, and also having to go home and deal with the things that we have to deal with in our community. We may be the person who are the head of our household. So we're not only taking care of our children, we may be taking care of our parents, we may be taking care of our siblings. So we have a lot going on. So understanding that, and I really try to stress that a lot, because even sitting in the city that we're in, we still hear that narrative of this is a poor Black woman problem. And it definitely is not a poor Black woman problem. And we have to make sure in these big hospital settings that they have people that look like me in leadership. They have people that speak up. They have people that advocate for their patients, because sometimes the patients don't know how to advocate for themselves, or they feel like if they advocate that they're going to be, deemed as aggressive, angry, violent. So having people in those settings that are there to advocate for them when they're just misunderstood, or they just need to talk, or it's not always an issue of their, not coming to their prenatal appointments. Okay, so how about we sit down and talk to this mom and figure out why she's not coming to her prenatal appointments, and let's solve the issue instead of assuming why she's not coming to her prenatal appointments, because there are barriers that we have to address. And if you don't address those barriers, and if you don't go into those communities and talk to those families and see, hey, what is it that you need? Instead of going into those communities that we see now, we go into those communities and we say, okay, we're going to give you A, B, and C. Well, they don't need A, B, and C. So if you don't know that, and if you don't walk into those communities, you don't go to those community meetings, you don't go to those barbershops, those beauty shops, those libraries, those community centers, and ask that community what they need, then there's no way we can solve the problem of decreasing the health disparities that we have today.
Thank you. You kind of addressed how some of the big hospitals and clinics can do better when it comes to taking care of Black mothers and babies already, but maybe you can talk a little bit about your clinic. You mentioned in our prep session about specific examples of having the mother be seen herself along with prenatal, with the checkups for the child. So can you talk like very practical examples of what you guys have done differently from the hospital setting?
Yeah, I think for us, we're action-based, right? So a lot of times when you work in institutions, there's a meeting after the meeting, after the meeting, after the meeting to decide what you're going to do, right? We know what the issue is. We have decades of data about health disparities, maternal mental health disparities, infant mortality, maternal mortality. We have enough data to know what needs to be done. And when you're an expert in the field, A, being a Black woman, A, living in a community where your patients are coming from, and speaking to that community, what that community needs. So for us, we noticed that about 50% of our moms weren't coming to their postpartum appointments. Why is that? It's because I got to get back to work. I can't stay off work because A, I can't afford to stay off work. B, I don't want to look like I need to stay off work because then I'm deemed as a woman in leadership as I can't do my job and I'm weak and I can't, do what I need to do. So I need to get back to work. But I'm going to make sure that my baby gets to her well child appointments. So for us, it's, following studies. We follow the evidence. Johns Hopkins did a study in 2014, and that study looked at women who putting those appointments in the same room at the same time. So what we decided to do is have our postpartum and our pediatric appointments, same time, same room, with the midwife, with the nurse practitioner. Mom is getting her postpartum checkup, baby is getting their well child visit. So I'm able to see mom, I'm able to put eyes on mom and notice if there's some changes. You came in here for your prenatal appointments and you were dressed up, you had on heels, you look good, and now you're here and you don't look the same. So I need to see what's going on. So being able to do those depression skills, being able to check blood pressures, being able to do all of that to decrease that maternal mortality rate, and having that mom in that room with the baby and also the dad or whoever that support person is. So taking care of that whole family for that first year of life is important for us, because we know a lot of things can change in that first year of life. So being able to have those visits together, co-located in the same room at the same time, so you're not missing work, you're not having to go across town for your appointment, the other side of town for your pediatric appointment for your baby, and bringing those moms together and their families and their babies and bringing it back to families and not taking away. It's like, oh, it's the baby and then there's a mom and then there's a dad. No, there's the family. And if that family is not healthy, that baby is not healthy. So we want to make sure that we're keeping that baby healthy, and also making sure that mom and that dad is healthy as well with our PEDS postpartum model.
Great. Thank you so much, Tanisha, for sharing all of that. Now I'd like to turn it to Dr. Elizabeth Vermilia. Thank you so much for waiting. I'm also very excited to hear about your solutions that are in practice. A trusted family partner. Can you please talk about a little bit about what is a family resource center, and how common are these centers across the U.S.?
Sure. I feel like Tanisha just teed it up for me there. It's great to be on the panel. I've been taking notes. If you see me moving around, that's what I've been doing. So family resource centers are community-based resource hubs, and they're places where families can come and have formal, informal supports. You know, listening to Dr. Deckel talk about shame as a key feature that moms are experiencing. Shame is healed in community. And we become the community where it's safe to be yourself, where you don't have to come look for services, quote unquote. You can come have some coffee, have some chat time while your child plays in the corner with some toys, and just have some, you know, community, adult time. Family resource centers are often, you know, they're best when they're embedded in the communities they serve, where parents are already going. So we have one in an elementary school. And they vary as far as services, I guess, and things they provide, but it's common to have parent education. There's often mental health support access. You know, we bring in a dental team, we bring in the vision bus, you know, the healthcare. You can get food. We have a little pantry there. You can get diapers, clothing. So the key is that they're community focused, like Tanisha said, and they're responsive to the specific needs, cultures, and interests of the community they serve. You hire in from the community you serve, so you're already hiring in those trusted people who are connected already. And although there's no dedicated funding, federal funding for FRCs, there are more than 3,000 nationwide. There is a whole bank of data, which I've included in the materials that you can access through FUVA. There's the money cost benefit analysis is well established. For example, in Kentucky, they prioritized family resource centers 30 years ago as a part of a statewide education reform effort. And they credit these family resource centers with moving the state from 45th place educationally in 1990 to being the top 15 school systems in the country. So if you don't think there's a cost, benefit there, all you have to do is look at the numbers. We also like to think about bringing community to support family. And this is kind of at odds with the traditional American thinking of rugged individualism. When we look at the theory of trauma, and we look at what's already been discussed with ACEs and Dr. Deckel's research, we know that also from Bruce Perry, the human brain is not designed for the modern world. We're designed to live in small, multi-generational, multi-family groups with higher ratios of caregiver to young child, you know, a 4-to-1 caregiver to child ratio versus the 1-to-4, where you go home with that new baby and you have the other kids at home and you're meant to just manage it all. And I really think about, I have a friend whose mom is there every day supporting her with her new child. And there are people talking about it like, gosh, she's over-involved. She's not over-involved. She's perfectly involved. The child is absolutely supported, happy, and the mom and the dad. So the Family Resource Center is what Tanisha was talking about, the place where we're taking the entire family group and embracing and supporting what they need from their point of view. You're muted, Anna.
Thank you for letting me know.
Sure.
So yeah, thank you so much is what I had just said. In our prep session, you spoke about very practical examples like diaper programs. And so my question is, how do you get the community to keep coming to these programs? And my second part of this two-part question is, what is the best way to get your community a family resource center? And how do you go about doing that?
Okay, so we need a whole workshop on that, but okay, leverage partnerships. People are already doing this work in the community. You want to go do what Tanisha said, go be places with people, spend time. spend time without an agenda, and listen more than you talk. So in those partnerships, we have connections with our schools. Parents are already at the schools. If you present yourself as a support and a solution, and you're bridging the gap that they've identified, our schools had already done their needs assessments. They knew what they needed. What we did was braid funding from a workforce development grant for community health workers. And so we had to go, shake the couch cushions to get the money. The school, found some money, but we braided that together. We met the need expressed. And as Tanisha said, not the one that we thought was needing to be met, but the one that was actually needing to be met. And we do a continuous assessment. So the degree to which you become a known support in the community is the degree to which you can perpetuate that. Now, we've been at this school since, not even a full year. And everyone in that community is looking at the funding to keep it going. So we are looking at all kinds of sources. But when we can go in and say that, every dollar invested in the community partnership in Teller County, Colorado, estimated a $3 savings, for other expenses, we're giving real-time upstream investment value. The other thing is that we need to be clear that we're going to access families where they need it. So we have a diaper project, right? And a lot of people come get diapers from us every Saturday. We have a sign-up sheet. We're able to communicate with those families. When you come in, then we're going to have PGE, right, our energy company, show up and have a booth where you can sign up for their care, for their reduced cost utility program, which a lot of these families don't know about, right? So once we have that relationship beginning where we're providing for your basic needs, then we can have a chat. Then we can invite you to coffee. Then we can really listen and hear what's going on in your life. This community we set up the FRC, we found, is highly populated with asylum seekers. So now we're bringing in legal aid. We're bringing in, professionals who can actually help, and they will engage because they trust us. And we will leverage that trust responsibly every step of the way.
Thank you so much. So we only have 3 minutes left here, but just wanted to kind of do like a firing round for all of you guys. In our audience today, we have change makers when it comes to maternal health and maternal mental health. Joy calls them the 4 Ps, which are payers, partners, providers, and policymakers. So with that in mind, just as a concluding thing to what we just talked about, what are some takeaways that this audience can take from this panel? I'll start with Dr. Johnson.
Thanks. I'm so absorbed in what everyone's been saying. It's been really wonderful to hear and hopeful. Okay, I think, we are doing this work in so many ways. We are trying to re-knit the mind and the body together in our systems. We are lifting up equity. We're trying to listen to patients. And so bringing a trauma lens, which includes how early experience affects our later experiences, for clinicians and individual providers, seeing the therapeutic value of our own interconnection, and also how we can support our patients by providing these connections to Tanisha, to Elizabeth, to Dr. Deckel. All of these connections are something that we can do, as well as our individual presence and holistic plans. And then the payers and providers, please help us stand these systems up in a way that really integrate this understanding. We're at a big opportunity here where systems are starting to shift to try and integrate physical health and mental health. Let's not leave this bigger picture, this life course picture, this community-oriented picture, this understanding of the wisdom of trauma and resilience out of it, please. And that concretely, that looks like helping these partnerships, having coordinators in the clinic that can broker these relationships and get people from medical care to community resources and mental health. So just the logistics and the support, we need it. And so appreciate your attention. Great. Thank you. Dr. Deckel? This is firing round.
Echoing what Dr. Johnson said about, I think it's important to remember that we are in the right direction. So much has changed, and there is much more desire for integration, not only by patients and those who are within the psychiatry department, but also within OB care and providers of OB care. So everybody, I think, is thinking the way we should think about this holistic care, and how there is more and more research that shows that mental health impacts the physical health and vice versa. So I think it's not so much about, okay, let's make sure we screen for depression. It's, kind of falls into this like holistic approach that if we are screening for depression or screening for PTSD, which is something that is definitely still lacking and not in routine care, this would have a direct impact on the birth outcomes, on the outcomes of the mother postpartum, physically and mentally, and on the outcomes of a developing child. So there's only one way to, I think, ensure that our society is healthy, by integrating and continuing to integrate the mental health component within the routine OB care to really optimize the birth outcomes of mothers, especially focusing on underrepresented minorities.
Okay, unfortunately, we're running out of time, so just one line from both of you. Tanisha, please.
Just to piggyback off Dr. Johnson, Dr. Deco, and Elizabeth, funders, you have to fund this work. It works, and without funding, we can't do what we do.
Thank you. Dr. Vermilio.
If you want resilient families, resilient mothers, you have to give them hope, because hope is the mindset that drives resilient behavior. So fund us, please.
Great. Thank you so much. So thank you, everybody. I think the great thing about holistic support is that it can be done now, as opposed to so many other hurdles that take decades. So thank you so much to the panel. Thank you for the audience. Joy, I'd like to hand it back to you.
Great. And I just want to share with the panel that we heard your needs and are going to take those back to the right Ps. Lots of light bulbs going off here. So thank you for your wisdom and your boots on the ground experience and research. And thank you, Anna. We hope to continue to see you cover maternal mental health in your work.